Diverticular disease. A diverticulum is a sac-like outpouching of the lining of the bowel that extends through a defect in the muscle layer. Diverticula may occur anywhere along the GI tract. Diverticulosis exists when multiple diverticula are present without inflammation or symptoms. Diverticular disease of the colon is very common in developed countries and prevalence increases with the age. Diverticulitis results when food and bacteria retained in the diverticulum produce infection and inflammation that can impede drainage and lead to perforation or abscess formation. Diverticulitis is most common in the sigmoid colon. Diverticulitis may occur in acute attacks or may persist as a continuing smoldering infection. Most patients remain entirely asymptomatic. The symptoms manifested generally result from its potential complications, that are abscesses, fistulas, obstruction, and hemorrhage. Pathophysiology. A diverticulum forms when the mucosa and submucosal layers of the colon herniate through the muscular wall because of high intraluminal pressure, low volume in the colon, that is fiber deficient contents, and decreased muscle strength in the colon wall, that is muscular hypertrophy from hardened fecal masses. Bowel contents can accumulate in the diverticulum and decompose, causing inflammation and infection. A diverticulum can become obstructed and then inflamed if the obstruction continues. The inflammation tends to spread to the surrounding bowel wall, giving rise to irritability and spasticity of the colon, that is diverticulitis. Abscesses develop and may eventually perforate, leading to peritonitis and erosion of the blood vessel, that is arterial, with bleeding. Clinical manifestations. Chronic constipation often precedes the development of diverticulosis by many years. Frequently, no problematic symptoms occur with diverticulosis. Signs of acute diverticulosis are bowel irregularity and intervals of diarrhea, abrupt onset of crampy pain in the left lower quadrant of the abdomen, and a low-grade fever. The patient may have nausea and anorexia, and some bloating or abdominal distension may occur. With repeated local inflammation of the diverticula, the large bowel may narrow with fibrotic strictures, leading to cramps, narrow stools, and increased constipation. Weakness, fatigue, and anorexia are common symptoms. With acute diverticulosis, the patient reports mild to severe pain in the lower left quadrant. The condition, if untreated, can lead to septicemia. Assessment and diagnostic findings. A CT scan is the procedure of choice and can reveal abscesses. Abdominal X-ray findings may demonstrate free air under the diaphragm if a perforation has occurred from the diverticulitis. Diverticulitis may be diagnosed using barium enema, which shows narrowing of the colon and thickened muscle layers. If there are symptoms of peritoneal irritation, and when a diagnosis of diverticulitis, barium enema is contraindicated because of potential for perforation. So, in peritoneal irritation symptoms occurs, barium enema is contraindicated. A colonoscopy may be performed if there is no acute diverticulitis or after resolution of an acute episode to visualize the colon, determine the extent of the disease, and rule out the other conditions. Laboratory tests include complete blood cell count, revealing the elevated leukocyte count and elevated sedimentation rate. So, CT scan, X-ray, the main thing. Barium enema if there is no peritoneal irritation. Colonoscopy to visualize the colon after resolution of the episode. And laboratory include complete blood cell count, elevated leukocyte count, and to check the erythrocyte sedimentation rate, ESR. Complications of diverticulitis include peritonitis, abscess formation, and bleeding. If an abscess develops, an associated findings are tenderness, palpable mass, fever, and leukocytosis. An inflamed diverticulum that perforates results in abdominal pain localized over the involvement segment, usually the sigmoid. Local abscesses or peritonitis follows. Abdominal pain, a rigid board-like abdomen, loss of bowel sounds, and signs and symptoms of shock occur with peritonitis. Non-inflamed or slightly inflamed diverticula may erode areas adjacent to arterial branches, causing massive rectal bleeding. Medical management, dietary and medication management. Diverticulitis can usually be treated on an outpatient basis with diet and medicine therapy. When symptoms occur, rest, analgesics, and antispasmodics are recommended. Initially, the diet is clear fluid, liquid diet until the inflammation subsides. Then a high fiber, low fat diet is recommended. This type of diet helps to increase stool volume, decrease colonic transit time, and reduce intraluminal pressure. Antibiotics are prescribed for 7 to 10 days. A bulk forming laxative also is prescribed. In acute cases of diverticulitis with significant symptoms, hospitalization is required. Hospitalization is often indicated for those who are elderly, immunocompromised, or taking corticosteroids. Withholding oral intake, administering intravenous fluids, and instituting nasogastric suctioning if vomiting or distension occurs rest the bowel. Broad spectrum antibiotics are prescribed for 7 to 10 days, and opioid is prescribed for pain relief. Morphine is not used because it increases the sedimentation and intraluminal pressures. Oral intake is prescribed as symptoms subside. A low fiber diet may be necessary until signs of infection decrease. Antispasmodics such as propantheline bromide, that is probanthine, PROBANTHINE, and oxyphencyclamine. Oxyphencyclamine, that is Daricon, OXYPHENCYCLIMINE. Oxyphencyclamine may be prescribed. Normal stools can be achieved by using bulk preparations, that is metamucil or stool softeners, Colis, by instilling warm oil into the rectum or by inserting an evacuant suppository, that is Dalcolax. Such as prophylactic plan can reduce the bacterial flora of the bowel, diminish the bulk of stool, and soften the fecal mass so that it moves more easily through the area of inflammatory obstruction. Surgical management. Although acute diverticulitis usually subside with medical management, immediate surgical intervention is necessary if complications, that is perforation, peritonitis, abscess formation, hemorrhage, and obstruction occurs. Alternatively, when the acute episode of diverticulitis resolves, surgery may be recommended to prevent repeated episodes. Two types of surgery are considered. One stage resection in which the inflamed area is removed and a primary end-to-end anastomosis is completed. The second one, multiple staged procedures for complications such as obstruction or perforation. The type of surgery performed depends on the extent of complications found during surgery. When possible, the area of diverticulitis is resected and the remaining bowel is joined end to end, that is primary resection and end-to-end anastomosis. This is performed through traditional surgical or laparoscopically assisted colectomy. A two-stage resection may be performed in which the deceased colon is resected as in one-stage procedure, but no anastomosis is performed. Both ends of the bowel are brought out onto the abdomen as stomas. This double barrel colostomy is then re-anastomosed in the later procedure. Fecal diversion procedures are discussed. Thank you.